So you all know what this is, but let me see. So let's. Okay. What? Justin, why is this thing doing this?
That's the first line.
Okay. So many times people don't understand the difference between a seizure and an epilepsy. A seizure is really clinical manifestation of abnormal, excessive, synchronous, keyword, neuronal electrical activity. So when you're having a seizure, you're having synchronous neuronal electrical activity. Normal neuronal activities are non-synchronous because neurons become more resistant to firing for a period of time after firing an action potential. Remember, when we talk about cardiology, we talk about refractory period, right? Absolute and relative refractory period. That is true for all excitable tissues. Okay? So generally speaking, neuronal electrical activities, normal ones, are non-synchronous. Neurons in seizure focus of the brain fire in an abnormal, excessive, synchronous. That keyword is important. Due either to upregulation of excitatory circuit or downregulation of inhibitory circuit. All of these is just, bottom line here, a seizure is a motor manifestation of abnormal neuronal synchronous discharge. That's what it is. Your hand cannot move unless something fires in your brain. A neuron has to have fired for your hand to move. Okay? Now, what is epilepsy? Epilepsy is two or more seizures over a 24 period apart due to a chronic, unknown, or uncorrectable underlying process. So if somebody has two seizures in one day, that is not epilepsy. Okay? You have to have two seizures, and the time between the two of them must be more than 24 hours. And secondly, there must not be an underlying process. So if somebody had 3 seizures in one day, and you took them to the emergency room and they did a CT scan, and they found a brain tumor causing the seizure, that is not epilepsy. Okay? You call it epilepsy when it is due to a chronic or uncorrectable underlying process. Okay? Epilepsy is a clinical syndrome, not a specific disease. Okay? What causes epilepsy or seizures? As you can see, it's very complicated, right? Everything and anything can cause it. From neurodegenerative disorders like Alzheimer's disease, 2/3 of it. What is important here? Put it simply.
You skipped the slide here.
I did?
Yeah. There you go.
It doesn't move when it's supposed to move, then it takes giant leaps. Okay. So, how do we classify seizures? That's you.
Thank you.
Basically, the International League Against Epilepsy classifies seizure as focal or generalized. Focal seizure means the seizure is coming from a specific part of the brain. It's not all over the place. Now, depending on which part of the brain the seizure is affecting, the manifestation can be sensory, special sensory, general sensory, it could be motor, it could be autonomic, it could be cognitive, or it could be psychiatric. Okay? Like when I came in here now and I disrupted you guys, that could have been a seizure. Right? Or it could be a jerk, like of the hand. It could be a smell. So if somebody comes and tells you, I'm always smelling rotting bodies. It's like once or twice a week I will smell something like a dead animal, and it will come for like a few seconds and it will go away. And it keeps happening repeatedly. That could be a form of an olfactory seizure. Okay? Or somebody hears voices. How do you tell when somebody is crazy versus when they're having seizures? When somebody hears voices as a result of seizure, they hear the same voice, tell them the same thing, and they generally don't talk back. When you have psychosis, this person is going to have a conversation with that voice. Okay? So it tends to be more conversational. So depending on which area of the brain a focal seizure is coming from, the manifestations can be very different. It could go from sensory to motor to psychiatric to cognitive. But the key word, the most important point about focal seizures is that consciousness is preserved. Okay? Consciousness tends to be preserved in focal seizures. There's only one exception to that. Except in patients with what is called temporal lobe epilepsy or complex partial epilepsy. Okay? So complex partial epilepsy is a kind of focal seizure that interferes with the level of consciousness. That is unusual. You don't find that usually with focal seizures. Now, generalized seizures are classified into 5 basic categories. You have the absence attack. Don't call it absence because it's French. Absence attack. They just lose consciousness. Typically, in absence attack, the patient does not lose postural tone. So, they could be in the middle of a sentence and they will pause for like 10 seconds. And then they will pick right back up. Like just for that 10 seconds, they're just absent. Sometimes it could be atypical where this person will actually carry out very complex motor activity that they are not aware of. So, walk up to Christian, take his glasses, smash it, and go right back in. And he'll be like, "What's up with you, man?" And I'll turn around and say, "Why are you standing? Sit there, you're supposed to be in class." And I have no recollection for what I just did. Okay? So absence attack, typically they just are absent. But sometimes in that absent mode, they can carry out very complex motor tasks for which they have no recollection or even memory. Okay? So it could be active. Then the other one in generalized seizures is the atonic seizures. This is very common in kids. And what happens is they just lose tone in all of their muscles suddenly, like lightning. So you see the kid maybe sitting down will just fall face flat, boom, on the table. If he's eating, his face will end up in the cereal bowl. If he's standing, he just slops. The tone in the muscles just go, and the kids not. And many times, these kids, you see them, they wear helmets, they put all kind of stuff to protect them because many times, because of that, is head injury. Okay? In these atonic seizures. And then there is the tonic seizures, where all of a sudden there is increased tone in all of the muscles in the body at the same time. So the patient just stiffens up like that. And then in the chronic type, you get a complete movement, right? Like a myoclonic jerk, like a knee jerk, a muscle jerk. So it has both flexion and extension. And then there is combination of tonic and clonic called tonic-clonic. Now, one thing that you need to know about generalized seizures is that, generally speaking, there is no warning sign and there is loss of consciousness. But it has its own exception. Remember, in focal seizures, I told you that usually they have warning signs. They have a premonitory experience known as aura. Consciousness is preserved except when it's temporal lobe epilepsy, right? So those important exceptions are important. In generalized seizures, they have no warning sign and consciousness is always lost except in myoclonic seizures. So myoclonic seizure is a form of generalized seizure without loss of consciousness. Okay? Are we good? Excellent. So what are the causes of epilepsy? Look, a lot of it, as you can see. But see, as many as there are, 2 out of 3 of them, you will never find the cause. All right. So generally speaking, is that a question?
Yeah. Is a grand mal seizure the same thing as the
Tonic-clonic, yeah,
Okay.
yeah, yeah. Grand mal seizure is known as the same as tonic-clonic, and temporal lobe is known as petit mal.
Oh.
Okay? Yeah.
Grand mal.
Grand mal, that is big bad. Petit mal, small bad. Okay. But these are old terms for seizures. Okay? So as you can see, is a lot of causes for it. So generally speaking, when you see somebody with a seizure, you just do the basic metabolic workup. You do the CBC, you do the comprehensive metabolic panel, you do VDRL, basic stuff. Because most of the time, 2/3 of 2 out of every case, you will not be able to find out why the person is having this seizure. Invariably, you're going to end up diagnosing them as epileptic, and then you're going to treat it. Okay? So this list over here is not for you to start wasting your time and trying to memorize or remember. Any disease you mention can cause a seizure. So if somebody asks you, what are the causes of seizure on any round? If you remember the first 3 patients that you've seen, just repeat those diagnoses to them. No, there is no disease that cannot present a seizure. Trauma, infection, anything, cancers, all disease can present with seizure except hypoglycemia. Okay, hypoglycemia does not present with seizure. Doesn't make sense. Okay, all right. So, like I was telling you, these are the clinical manifestations of a focal seizure. Look at this picture, just told you everything, right? There is the precentral gyrus, the postcentral, motor and sensory cortices, right? And again, I'm telling you, preservation of consciousness with the sole exception of temporal lobe epilepsy, the petit mal seizure, okay? Controversial, and what you feel when you have a focal seizure depends on which part of the brain the defect is. And then these are generalized seizures, right? This is somebody in tonic phase, so you see how stiffened become. And this is somebody in the clonic phase, right? Generalized seizures proceeds in very, very, very precise sequence. The first thing that happens is loss of consciousness. Okay? And then the patient goes into the tonic phase. And then from the tonic phase, they enter into the clonic phase. It is during the clonic phase that they do damage.
I think you skipped this now.
I didn't skip anything.
You did that?
Yeah.
I guess I did.
I'm not having a seizure, believe me. Right? So, it is during the clonic phase that they do the most damage. to themselves. So when you're observing a seizure, don't try to hold the person. What you want to do is to take out everything around them that they could hit. Okay? Don't try to grab them. You can't. Okay? And then, very importantly, incontinence. Patients with generalized seizures, they will pee and poop on themselves. Okay? They bite their tongues, and we used to try to put mouth guard. It's a waste of time because sometimes trying to get the guard in, people's teeth have been knocked out and they recover from the seizures and then they never get the teeth back. Right? And in children, because of the clonic activity, breathing becomes irregular and the kids can become cyanotic. Okay? So that's the worst kind of seizure. That's why the French called it grand mal. Okay? Now look at atonic seizure. That's the one you lose postural tone, head drop, falls, drop attacks. That is, these are all the names that have been used to describe atonic seizures because the kids just drop attacks. They tend to last seconds, 1 or 2 seconds. But that's all you need to get a serious damage. If you were cooking in the kitchen and you're staring and you end up with a drop attack while you're doing that, you put your face right on that stove. So it takes just that much of a short time to kill the patient. Okay? The myoclonic seizures, again, synchronous muscle jerks. Notice preservation of the level of consciousness. Very important. And this is your absence seizures. A brief blank stare for about 15 seconds. It starts suddenly, stops suddenly. Sometimes when patients are having this absence attack, they tend to have these things called automatisms. So if I was to have a typical absence attack, it would look something like this. So I'm blanking out, but there is this little other movement that I'm making. It could be chewing, it could be this, it could be, you know how some people are in the middle of the sentence like, that could be an absence attack. You know, you see those fine motor activities that you see sometimes in patients with absence attack, they call automatisms. Why are they important? Automatisms are the...
The automatisms you have, there are no automatisms there.
Sorry. Automatisms are what you see in complex partial seizures, in temporal lobe epilepsy. Thank you. Automatisms, I put them here. I mostly wanted to tell you that in absence attack, there are no automatisms. So if somebody has an absence attack and they exhibit any motor manifestation, that is a strike against absence. It makes it more likely that this is petit mal. It makes it more likely that this is indeed a temporal lobe seizure. Thank you so much. Right.
Right, so they don't have the final.
They do not have automatisms. Those fine motor motion I was demonstrating. It is an exclusion, not, it is what excludes, not implicates absence attack. If you find automatisms, that means your patient does not have absence. It's more likely this is a temporal lobe epilepsy or petit mal. I'm sorry, I flipped the script. Are we good? Okay. Now, sometimes, instead of having distinct types of generalized seizures like absence, tonic, clonic, or grand mal, patients will have combination of these generalized seizures. One important combination generalized seizure is what is called the juvenile myoclonic epilepsy. So usually what happens is these patients, they have a myoclonic seizure. But in addition to that myoclonic seizure, they can also exhibit grand mal or absence. So they have more than one type of seizure. Why is this important? Whenever you see this, that usually means that this person is going to need to be on anti-epileptic medication for life. Okay? So when you're taking a history of seizure, it is not enough for you to say, oh, the mom said he has seizures and he had grandma seizures. It's not, I mean, you have to, how long has he had it? Has the pattern ever changed? Has the patient ever had a seizure that ordinarily when they have seizures, they pass out and they start shaking, but have they ever had one where they didn't pass out? Or were there moments where they just there? So if somebody reports, my husband or my wife has grand mal seizures, but there are times he stares and he doesn't have a seizure. They look like incomplete seizures, like he was about to have a seizure, and then we started praying, then he stopped. Right? That is how usually they will paint the picture for you. You need to step back and say, okay, how many times does that happen? So, well, you will have a big seizure like maybe every other week, but it gets this other absence like the one we really pray against, and then you get it like every other day. That is telling you right there that there are two kinds of seizures here. Whenever you find more than one type of seizure, and one of them is a myoclonic seizure, you're dealing with juvenile myoclonic epilepsy. Why do you have to make that specific diagnosis? Because most epileptic, if you can get them to be seizure-free for 2 years, you can declare them cured. But if your diagnosis is juvenile myoclonic epilepsy, you're never coming off of medication. They will always relapse within weeks of discontinuation of the medication. So we don't do that. That's why it's extremely important to look. This is one of the ways in which myoclonic seizures will present. Somebody went to the bathroom and they're trying to brush their teeth, and then they go into a myoclonus and they just throw the cleaner up like that. It drops, everything drops. That could happen if they're trying to serve their child coffee or tea, and they'll just have the attack and they'll spill everything on the kid, right? So that's what that picture is portraying to you. And when you look at EEG, you will see bilateral generalized, they call them 4 to 6 spikes wave or poly spikes. Don't worry about that, I just put it there.
So juvenile is just multiple, those
It's
three?
a combination generalized seizure syndrome characterized by myoclonic plus seizures. So it's myoclonic plus one other seizure. It could be anything. It could be absence, it could be anything else. But it's a complex of generalized seizures. Okay? You cannot call it juvenile myoclonic epilepsy if one of the seizures is a partial seizures. Remember that, it's a focal seizures. No, it's got to be a combination of generalized seizures. Very important. Okay? So if I want to kind of trick you in an exam, I'll give you a story of combination seizures. I'll make one a focal seizure, make the other a myoclonic seizure. You will not call that juvenile myoclonic, because in order for it to be juvenile myoclonic epilepsy, the both types of seizures have to both be generalized type. Okay? Yes?
So, so in this case, this patient cannot have no like comorbidity, right?
No.
Because what if there's like a patient who has cerebral palsy but also has this type of seizures? Is it then just called epilepsy?
Yeah.
No.
Yeah. It is epilepsy if you don't have, you can't correct it. the underlying condition cannot be fixed, right? Now, generally speaking, after a seizure, the patient goes into a post-ictal period. Ictus is another name, Latin for seizure. Okay? So when we say post-ictal, that is the period after the seizure. Okay? In the post-ictal phase, the patient is breathing normal. They tend to be drowsy for about an hour or so after the seizure. They generally do not remember the seizure or any event around it. They will have headaches. They may appear confused. They may even have weakness. Now, that weakness is very important, because if a patient with a focal seizure experiences weakness after that seizure in that same part of the body, almost always there is a structural basis for that seizure. Okay? So if you were, say, in a village in Guatemala, and you see a 23-year-old boy, and they say, oh, he's been having these seizures for 2 years now, and he's seen some native doctor, and they tell you that, oh, every time after the seizure, he's limp in that particular extremity for like 6 hours. If you can, through any means, get that kid to the country for them to do a CT scan, it's worth it. Because that means there is indeed a structural basis for that seizure. And if you do the surgery, you might just get rid of the seizure altogether. Yes?
Sorry, it's gonna backtrack a little bit, but you know how you said if you control somebody's seizures if they don't have a seizure for 2 years, that means it's considered cured? Is it true that like if you do surgery as well, you can be cured from epilepsy?
Yes, surgery never cures seizures. You can minimize it and rarely eliminate it. And the reason it never cures it is because invariably surgeries leave scar tissue, and scar tissue are also irritating to normal neuronal tissues. Okay. So why do we talk about Robert brain letharg? Because of post-ictal phase. That post-ictal period is very important, and you will understand why. If somebody, okay, if you see a patient and they say, doctor, I have seizures, say, you do? When was the last time you had one? I just had one yesterday. You did? Tell me about it. I was just trying to get ready for work and I had a seizure. How long did it last? For about 3 minutes. And then what happened? Then I went, after the seizure, I went and took a bath and I went to work. You know that patient is lying. Right? Generally speaking, seizures are diagnosed by an eyewitness. Patients don't know about it. And generally speaking, you don't come around immediately after a seizure, especially a grand mal seizure. You'll be drowsy for a good hour. That post-ictal phase has a very significant differential diagnosis. It has a very important differential diagnostic significance. Okay, you must look for it because there are psychogenic seizures. People want to be on disability. Nobody wants to work. If they can get some check they don't have to work for, they will lie to you. They will do whatever they have to do to get you to put them on disability. Okay, so that's why post-ictal phase is important. The second reason post-ictal period is important is because in patients with focal seizures, post-ictal paralysis can mean a structural basis for the seizure. Okay? Now, so that's how seizures generally present. There are times an epileptic seizure will last more than 5 minutes, or your patient will have 2 or more epileptic seizures without full recovery. So if somebody had a grand mal seizure and without regaining consciousness in their post-atrial phase, going into another grand mal, we call that status epilepticus. Okay? The commonest reason for it is poor adherence to anti-epileptic medication. And that is the reason we don't treat alcoholic with seizures with any medication. Because generally speaking, alcoholics are not good with adherence to any medicine, number one. Number two, alcohol itself is a known cause of seizures. So when you see an alcoholic epileptic, you don't know, is it the drinking that is causing the seizure, or is it his inability to keep adherent to his medication? Okay. How does it normally present? Generally speaking, it's a convulsive status epilepticus, so the patient deconvulses. But it could also be a non-convulsive type. That is more, a little rarer, but it's possible. How do you diagnose seizure or status epilepticus when your patient is not convulsing? Fluctuating level of consciousness in a critically ill patient. So you have a patient in the ICU, and today you go to see them, they're awake and they're talking to you and everything. And then the next morning, it appears like they're unconscious, they're not responding to you. They're not responding to you. You do CT scan of the head, you do all the examination, there is no abnormality. That is the time to do an EEG, because you will see the seizure on the EEG. Okay? So whenever you see fluctuating level of consciousness in a critically ill patient, and you're sure they're not delirious, you should think about a non-convulsive status epilepticus. Okay? Of course, how do you manage it? You resuscitate them with thiamine and glucose, give them pyridoxine, especially if they had been on INH. Because, as a matter of fact, INH typically present with epilepsy. Okay? Now, after resuscitation, the best medications that you want to use to interrupt epilepsy are benzodiazepines. Lorazepam is your first choice, but you can use diazepam and you can use midazolam. They're all benzodiazepines. The commonest one, the one you should know, is lorazepam. Okay? Then after you have aborted the seizure with a benzodiazepine, you keep the patient seizure-free with epileptic medication. Usually you will use phenytoin drip. The first time we use phenytoin drip, patients turned purple in their hand, because it turns out that when phenytoin extravasates, leaks out of the vein into the tissue, it is terribly, terribly toxic to the soft tissue, and it causes a lot of problems. Then the pharmaceutical company found a way to make money. So they now start manufacturing phenytoin. The difference between phenytoin and phenytoin is that phenytoin is a prodrug. It goes in through the vein and it goes into the system. And once inside the system, it is then converted into phenytoin. So you get to give your patient phenytoin without the purple glove syndrome. Other alternatives, valproic acid. Valproic acid is a second-line medication. What you really want to use is phenytoin, right? But if somebody has allergy to phenytoin, then you can give them valproic acid. The most expensive thing you can use is levetiracetam, and it's expensive, but it's available Okay. Now, if you're not able to abort the seizure with the benzodiazepine, and you're having difficulty controlling the seizure with phenytoin, then last line, you call in the anesthetic guys, and they will just paralyze the patient. Okay? They just paralyze the patient, because once the patient is paralyzed, you disconnect the neurons from the muscle, right? It does not mean the patient is not seizing, but the seizure will no longer be clinically apparent. So you have to now monitor the EEG to see how well your anti-epileptic medications are working. You got that? This is what purple glove syndrome looks like. It's a rare complication of phenytoin extravasation, usually avoided by the use of blood drug, phenytoin. All right? How do you diagnose epilepsy? EEG. Okay, you see, normal EEG looks like this. Okay? And you can see all these partial epileptic bursts in focal seizures, and you see generalized seizures like this. Do you really need EEG to diagnose epilepsy? No, you don't. The diagnosis of epileptic seizures is usually based on clinical observation and witness accounts. EEG is used to determine the type of epileptic seizures. Okay? Because sometimes the characteristics might be confusing, especially in somebody with JME, juvenile myoclonic epilepsy, where you have a combination of generalized seizures. It might be difficult to tell complex partial from absence, right? So you use EEG to characterize the seizure, but the diagnosis of epilepsy is by history, eyewitness account, not from your patient, usually from an eyewitness. Don't forget that. Now, I just told you that people lie sometimes, and they will come to you and they will tell you they have seizures because they want you to put them on disability. You must be able to tell somebody with a real seizure from a false seizure. I found this table, I think it was very cool, very indicative, very exhaustive, right? And it tells you that if somebody is lying to you, they will give you a history that does not even resemble a seizure. Okay, they will not be able to. If somebody is trying to describe to you their own seizures, they are lying to you, because you don't see yourself seizing; others see you. And then you ask them, "Do you bite your tongue?" They never bite it. Nobody hurt themselves trying to get that disability, right? Duration, true seizures tend to be very short. Wait till it, I didn't come to work last night because I was having seizures. Really? How long? All day. And then, see what I'm saying? Post-ictal phenomenon, generally absent in pseudo seizures. Right? They never injure themselves. Occurring during sleep, seizures occur in sleep. Only when they are fake, you don't see them. Can be precipitated by suggestion. Yes. If you suggest to the patient, so when you get the seizures when do you normally get the seizures? Like when you're angry or hungry? Yeah. You see, they respond like that to autosuggestion. Patients with true seizures, like, "Doc, I get it any time, man. I get it." They don't jump at the opportunity to suggest that any particular thing is causing it. Because when you suggest to them, you convey the impression that you're validating the symptom, and the patients will respond to you when they are pseudo seizures. Mm-hmm. Of course, EEG is almost always normal, both within and during and after the attack. Even when patients are not having seizures, patients with true epilepsy have interictal abnormalities on EEG. In between attacks, their EEGs are not normal. Okay? So that EEG in between attacks is what we call interictal. You got that? Okay. And for some odd reason, in true seizures, serum prolactin tends to be elevated after the attack, whereas in pseudo seizures it doesn't happen. But you never get to do that. You never get to measure serum prolactin to tell the difference between pseudo and true seizures. Nobody will pay for that. And unfortunately, if somebody gets you to put them on seizure medication that they don't need, you can actually precipitate seizures. So you can imagine somebody comes to you to lie that they want disability and they fake the seizure story, and then you prescribe the seizure medication, then they get the real seizures. And then, of course, what do you think they will do? They will stop taking it. Right? And they come to you, say, thank you, doc, that medicine is working wonders. I've not had a seizure since the last time I saw you. Then you draw the blood to measure the serum level of the seizure medication, and the medication is absent from the blood. So you know you've been conned. All right. But in addition to pseudo seizures, there are other differential diagnoses. I don't agree with much of what is here, but it's in the books. The only two that I really think are true differential diagnosis is pseudo seizure and syncope. So I've already given you how you can tell pseudo seizures from true seizures. Everything else here, you will be able to tell. Sleep disorders, hypoperfusion, cardiac arrhythmia, emotional outburst, dissociative fugue, drop attacks, migraine, hypoglycemia, come on. These are not legitimate differential diagnoses, but they are in the books, in most of the standard books actually. The only two differential diagnoses of seizures are pseudo seizures and syncope. So anytime you have a patient with real seizures and you do your basic biochemical workup, two things that your workup will not distinguish for you is pseudo seizure and syncope. You have to understand how to tell those apart clinically. Okay? Let me tell you, how do you tell syncope apart from seizures? Seizures tend to have some warning sign. Syncope also has warning sign. But the warning signs of syncope tends to be cardiovascular in origin. Okay? Seizures, they happen suddenly, and they can happen in any position. You can have a seizure in bed while you're sleeping in the night. You can have a seizure where you're sitting on the couch. You can have a seizure in any position at any time. Generally speaking, you get syncope when you're in an erect posture. Either you're sitting up or you're standing up. If you always get your seizures when you are changing position, something is wrong. That may not be a seizure. Okay? And of course, you have the characteristic muscle tone changes that you don't find in syncope. And again, post-ictal. The post-ictal confusion, again, is completely absent in patients with syncope. Now, there is a condition in which somebody can actually, and of course, the incontinence you find with seizures, you never find with syncope. So you see the importance of reviewing systems when you're seeing patients. That will help you differentiate syncope from seizures. But there is something else that I need you to know. If somebody is about to have syncope and they are falling, and some good Samaritan runs to them, say, Dad, what's going on? And holds them up. Because they are having syncope, that means something is wrong with the heart, right? Some dysrhythmia has cut off blood flow to the brain. And instead of allowing them to fall to the ground so that gravity can restore cerebral perfusion, you hold them up and asking, Dad, you prolong the cerebral hypoperfusion and you actually precipitate a seizure. Okay, so it's extremely important to take a good history. Tell me what happened. We're in the kitchen cooking, and all of a sudden she started slurring in her speech, and then she dropped the spoon, and I held her up. I tried to walk her to the living room, and then she had a seizure. That is syncope, precipitating seizure. Okay? Oh, but she was cooking in the kitchen, and all of a sudden she dropped the spoon and fell backward. That is a seizure. So extremely important. It is only by history. There is no test here. It's only by history and clinical acumen that you can actually tell these two things apart. Again, if you're seeing somebody with seizure for the first time, you do your basic workup. CBC, you're looking for infection. Comprehensive metabolic panel, you're looking for electrolyte disturbances and metabolic disorders. You can do erythrocyte sedimentation rate, or you do the C-reactive protein, which is more expensive, but does not matter. Why are you doing that? You're looking for any underlying inflammation. Do a drug screen. Many of these shows stimulants, drugs can cause seizures. Do a urinalysis, okay? MRI, not CT, MRI is indicated for all first-time non-febrile seizures. You're looking for structural abnormalities. But if you think your patient had a seizure because they had a bleed, you will not do MRI, you will do CT scan, right? So say, for instance, you are in the urgent care or in the emergency room, and they brought somebody in for seizures, right? And the guy is awake now, talking to you, but his neck is stiff. He has positive Koenigs and Brzezinski. He just had a seizure, and he has positive Koenigs and Brzezinski, and it's not febrile, and he doesn't have elevated white count. You know, this is not likely to be meningitis. This is more likely to be subarachnoid hemorrhage, right? So what would you do? You will not do MRI of his brain, you do a CT scan, because you're looking for blood. Blood is a contrast, so you don't need contrast. So you're non-contrast CT. You got that? That's a good question. Yeah. Of course, if you are suspecting infection, you do lumbar puncture. Usually, fever will suggest that too. Okay? Let's see. All right? Are we good? You know when you should do CT scan now. Good. So, how do we treat epilepsy? Well, you don't put anybody on anticonvulsant after the first seizure. You don't. Okay? After the first seizure, well, unless you know that there is a structural basis for it. You understand what I'm saying? So if somebody has seizures, and CT scan shows they have pituitary tumor, immediately you put them on anticonvulsant, right? Because you know that this mass in the brain is causing the seizure, and unless you send them for surgery and they do the surgery, that mass is always going to cause the seizure. So you put them on anticonvulsant first time. If somebody had a seizure and you do a CT scan or MRI of their head and it's negative, you don't put them on anticonvulsant until they get the second seizure. Okay? Because you can get seizure from anger. You can get seizure from anything. Anything can cause seizures. It is when it becomes persistent and progressive that you call it epilepsy and you begin to think of actually treating it. Okay? And what are some of the specific medications that we have? There's a lot of seizure medicine, and they're still manufacturing new ones. But generally speaking, for focal seizures, we use carbamazepine or tegretol. Whereas, would you use carbamazepine? Trigeminal? Okay, all And then there is the newer one, levetiracetam or Keppra. The beautiful thing is that in somebody who is pregnant, you're better off with Keppra than Tegretol. Okay? So don't give pregnant people carbamazepine. Give them levetiracetam or Keppra. For generalized seizures, use valproic acid. These are cheap medication, and they're just as fine. And then Lamictal is a newer medication you can use when valproic acid is by itself is not effective. Both levetiracetam and lamotrigine or Lamictal are both safe in pregnancies. Valproic acid and carbamazepine are not as safe in pregnancy. Pay attention. Levetiracetam for focal, lamotrigine for generalized seizures. You have to use these medications specifically. You will never be forgiven if you give somebody Lamictal for a focal seizure or you give somebody Keppra for a generalized seizure. So extremely important. Put a circle around those two and make sure you remember them and never forget them. Now there are medications that you can use. It does not matter whether the patient is focal or generalized seizures. You see Dilantin or Tupamax, you can give anybody. So if you don't remember which one is what, give Dilantin. Okay. And then Topiramate. What else? What will make you specifically give somebody Topiramate that is non-seizure? What is it in the patient with an epilepsy will make you choose Topiramate against over phenytoin? Migraine. Remember? I hope you remember all these things. Whenever you are giving a patient anti-epileptic, remember to always start low and go slow. You monitor the serum level of the medication and you titrate the medication dose to seizure activity rather than serum drug levels. So if a patient comes to you and they've been on Dilantin for 3 years and they have not had a seizure in 6 months, and the lab is telling you that Dilantin level is below therapeutic level, but your patient has not had a seizure, don't change the dose, leave it alone. Okay, don't change the dose of your medication because of lab. Change it because of your patient. Okay, if your patient had a seizure between the first time, the last 2 visits, and then the Dilantin level returns below therapeutic level, and your patient is having a seizure, of course you will increase it. But your patient is fine, don't increase it. Why? The reason you don't want to do that is because fluctuations in the serum levels of anticonvulsant medication can and do precipitate seizures. Okay, that is why you don't want to change your medication because of a lab test. And if you have opportunity, always measure the free drug levels instead of the total drug level, because the total drug level is giving you the sum of both the free and the bound. The one that you really want is the free one. That is what is available to your patients. Okay. Again, if your patient is seizure-free for 2 years, and their seizures have been a single seizure type, and they have no structural lesion, and EEG is normal, you can pronounce them cured. Okay? EEG is normal, they have no structural lesion. So if somebody has, say for instance, they've had brain surgery for aneurysms, say they had aneurysm clipped 5 years ago, and then they developed seizure 2 years ago, you know that it is the surgery that is precipitating the seizure. So even if you keep that patient seizure-free for 2 years, you will not declare them cured, because the reason they're seizure-free is because of the medicine. There is a structural basis for that seizure. As such, your patient will never be cured until they get a new brain. Okay? Again, like I told you, helmet for atonic seizures, ketogenic diet never really did work. And then there are some dogs that can actually smell when their owners are about to have seizures. And they have this crazy, funny behavior at the back, they cry, and then their owners will know to go into a safer space. Like you may be swimming, and your dog is making that crazy noise, you run out of the pool quickly, because you know you're about to have a seizure. Okay? And sometimes patients will need you to certify that they need that dog, because some apartments don't allow pets, right? And then if you write it that this is a seizure response dog, then they will allow them. Okay? So it's important for you to know that. So look at all these medications that are available to you. It's a long list of medicines. You don't need to bother your head with all this, and this is the mechanism. They all work by blocking either the GABA or the sodium or the calcium channel. Nobody asked you that. I just gave you this list for you to know that there is a hell of a lot more medication to control seizures than carbamazepine, Lamictal, and Keppra. You just have to know that there are options. Generally speaking, neurologists put patients on these medicines. Okay, you don't. Other than, look, I've never put anybody on anything other than valproic acid, dilantin, clonidine, Keppra, and Lamictal. I'll use only those 5. Because that's what you use most of the time. It is when those are not working, and you send the patient to neurology, that then all these other ones come up. And then you now have to go study them, learn them, so you know what side effects to expect in your patient. Okay? When patients are on anti-epileptic drugs, you need to monitor them for serious drug-drug interactions. Not only do anti-epileptic drugs interact with themselves, together as a group, they interact with other medications. The good thing is that with all of this electronic health record these days, the machine will check for interaction for you, and it will warn you. 90% of the time, you will ignore the warning and put the patient on the medicine anyway, because you don't have options. Okay, unless it's a little interaction, and then the color will be red. Then you have to pay attention and make a conscious decision whether you still want to move ahead or you want to not go ahead. Many, many times, when it's red, you are required to stop. Okay, but in practice, how often have I stopped a medication because of the red alert? Yeah, maybe a couple of times. Most of the time, you don't have a choice. You have to just put it, and it's not red. Okay? So I gave you this not for you. I would never test you on this. I don't think anybody will. But you need to know that medications interact with themselves and with other medications. And in my next slide, I gave you examples of the mechanisms for interaction of AEDs, that is anti-epileptic drugs, and non-anti-epileptic drugs. Okay? The ones that you need to be aware of, look, the pyramid, it accelerates statin clearance. Okay? So if you're starting somebody on the pyramid, Supermax, and they are on statin, you better keep an eye on that statin or increase the dose. Otherwise, while you're trying to protect them from seizure, you will increase their risk for a heart attack. Right? So I put that one there. And then birth control. If your patient is on birth control pills and they have to go on the pyramid, you have to switch them to IUD or encourage them to use barrier method or both. Because the pyramid would accelerate the OCP metabolism and they could get pregnant. And they get pregnant on valproic acid, that is double trouble. Unwanted pregnancy, not certain the baby will be normal. Now you're going to have a debate, pro-life and pro-choice. And then accelerated vitamin D metabolism. All of this is through enzymatic induction. So you have somebody on dilantin for a long time. They are going to have osteoporosis at a much earlier age than they should. You need to be aware of that. So you can monitor the bone density. Because if you don't, yeah, you might keep them seizure free, and then they will trip at 40 and they'll break a hip. Then what have you done? Okay? So it's really important to be aware of all these side effects. And you're looking for a T-score less than 2.5. We'll talk about that in endocrinology when we talk about metabolic bone diseases. Now, if you cannot control seizures, you've done everything you can. You cannot control seizure. When do we call epilepsy intractable? Whenever you fail to control seizure after treatment with at least 2 appropriate, keyword, appropriate and adequately dosed anti-epileptic drugs for at least a year. Not only do you need to have the patient be on 2 drugs, they must be appropriate. So say for instance, you went and put the patient with focal seizure, right, on lamotrigine. And then after 2 years say, you have intractable epilepsy. You got the man on the wrong drug, right? Or you went and put the patient with generalized seizure on carbamazepine. Well, that's the wrong drug. You cannot, it's got to be appropriate medication. It's got to be adequately dosed. And the patient must be adherent. You must be sure to validate it, right? Verify it with serum levels. And they've been on it for 1 year. That is when you call it intractable. Okay? Now, what then do? You refer them to epileptic center. There are very few of them in the world. Okay? We have one in California. What do? Epileptic centers are neurologists. They will confirm by giving the patient 2 appropriate medication, adequately dosed for 1 year, and confirm that yes, this is indeed intractable. Then what are they going to do next? Then they have all these. The first thing they will do is they will do a vagal nerve stimulation. So it's a device, right? It's an implantable device, and they keep the vagal nerve stimulated, and somehow it reduces epilepsy. I don't know how that stuff works, okay? But apparently you need to know that. Now, vagal nerve stimulation does not always work. Now, when vagal nerve stimulation does not work, what is the next thing? You do a video EEG. Why? The reason they do a video EEG, when I was at UCLA, I was a patient escort, right? And I used to go take patients from these rooms to radiology and back and forth. That was when I messed up my back. I used to wonder, what are they doing to these people? Because they have them in all these rooms, and you see the patient on all these monitors, and you see these nurses, their eyes fixed on the monitor. I used to wonder, what are they doing? So apparently what they do is, they are comparing the EEG with the motor manifestation, right? They want to make sure that if the burst is coming from the frontal lobe, the patient's seizure is coming from their hand is shaking, right? If the patient is having epilepsy in the, say, parietal lobe, they will look, and the patient is complaining of numbness in that particular side. So they want to match the motor manifestation to the EEG manifestation. That is the point of video EEG. Okay, so video EEG is not a treatment. It's a way of matching the epileptic motor manifestation with a cortical neuronal activity for one purpose only: preoperative mapping. Because if you're sure that the epileptic discharges from the frontal lobe correspond to the motor manifestation, then you now go in and you're sure that if you can take out the temporal lobe or the frontal lobe, you will stop the epilepsy. You got it? And this is usually done a lot for petit mal surgery, because apparently temporal lobe epilepsy due to mesial temporal sclerosis, scarring associated with the hippocampal atrophy is the most common cause of drug-resistant epilepsy in adults. Okay? Yeah.
So what is considered like failure to control? Are you saying like they're on the medications and they still get the seizures once in a while, or they're
No.
like they don't get
Failure
it at
to
all?
control means your patient has been on 2 appropriate and adequately dosed medications, and they've been on it for at least a year, and they still continue to have seizures, as if nothing is happening. Every week, every month, does not matter.
So what if the seizures change up now though? Because like what if they're on the medication and they'll get it like, I don't want to say, yeah, basically like once in a blue. Is that considered intractable?
What is a blue? If a blue is
A blue is not like how they used to
every
get
6
it.
months, every if your patient get a seizure in a year
Okay.
on 2 adequately dosed medications, appropriate adequately dosed medications, they're intractable.
Okay.
You're supposed to be seizure free
Okay.
after 2 years on medications, and you keep adjusting it. But if you keep adjusting and you have them on at least 2 medications and they keep getting seizures, you can't get them to be seizure free for 1 year. That is the definition of intractable. Okay, at least textbook definition.
Okay. Another question. So if they don't do any of this, then what do they do medication wise? Like if they don't do the surgery or they've done all of this, but they end up not doing the surgery, now what?
I've
just
seen
gonna be
patients
intractable?
taking 3, 4,
Or they just keep putting
they
them
keep
on more medication?
combining, experimenting with, you see that long list of medication? They keep putting in and taking out. They know how to do it. I know how to do it for blood pressure and diabetes. Those neurologists, they know how to combine them. And these are active areas of active research to find out what's the best combination to when the regular medication does not work. Okay, any more questions? All right, people with controlled epileptic seizures who meet specific licensing criteria can drive in the US. You have to be controlled, and you can drive. But the duration for which you must be seizure-free is not the same. It varies from state to state, and it could be anywhere from 3 to 6 months. In 44 of the 50 states, it is the responsibility of the patient to report to DMV that they have seizures, right? But in 6 of the states, including California, you as a provider, you're required to report the patient to DMV because it has implications for their driving privilege. Okay? Pilots can never fly. They lose their license once they get diagnosed with seizures. There is no time, no duration. You can't, the pilot, you can't fly. Okay. Now, I want us to just come help me here. I have this thing. I'm hoping we can
Videos?
do the videos, right? Just post the link. We have some time. I want to. I just want you to have an idea of what a seizure looks like and how distressing it really could be. I think you need to open it. Okay, right there. Excellent. Good. All right. You see that? Look at this poor guy. Can you hear? I want you to listen to the sound he's making.
That's like the grandma.
What kind of seizure do you think this is?
No, that's not that. It says tonic-clonic right there.
He has, this is a grand mal seizure, right? You can see the arm is stiff, it's not moving, but his body is jerking like that. So this is a grand mal seizure. See, the poor guy is, the volume is not working.
Yeah, it's not working.
Okay, but he's making all this noise in his throat because the seizure is not only on the outside, it's also in his larynx. Okay, okay? And with the contraction of his thoracic muscles, is forcing in air and out, air in and out, and with laryngeal involvement, making all these strange noises. This is not a good thing. The vomit, you see the vomit there, and then you see him. Okay. No. No, wait. Oh.
You want me to reset it?
Yeah, reset it. Okay. I want you to. You see, it's turning chronic, right?
You want the other video too?
But then, you see, the seizure is like, you see, about 10-15 seconds, right? But pay attention to him when the shaking stops. That is a post-ictal state. You see, he didn't just stop and wake up. He's going to stay like that for a while. And the only way you will know that he had a seizure was because he would have peed and pooped on himself and would have vomited. He can't tell you what happened. Okay. So, what kind of seizure do you think this is? What kind of seizure is that? It's a partial seizure. Because she's moving. And you can see her eyes are rolling, right? So she's exhibiting automatism. Look at her lips. Right? If she was just a blank stare, it would have been absent. But because she's moving around, rolling her eyes, that is a complex partial seizure. Do you see what I mean by automatisms? Those movements, and you see how briefly it will last, and the next thing she will recover, and you can't even say, you can't tell anything happened. Thank you. So, you've seen the picture of a complex partial petit mal and grand mal. These are very distressing things. Imagine what this could do to a mother or a wife. It's devastating, to say the least. All right, so that is
Sorry, Dr. Martins, you said that one was a complex partial?
yes.
Because, so that means they don't lose consciousness all the time, because when you were saying partial, focal, you said there's no loss of consciousness except for
She wasn't
complex.
conscious.
She wasn't?
Mm-mm.
Oh, okay.
All
How do you tell?
because you could see that. Oh, okay. She was not following any particular gaze. If there was an emergency in that situation, that woman can't move. She was just, you could see how helplessly she sat there and was just, her eyes and her lips were just moving, and her eyes, she's not following any particular person. She's absent right there. So it looks like an absence attack, but the automatisms is what makes it, this is more likely to be petit mal. Okay? She's not conscious. Okay. Now, let's talk about movement disorders. Now, how do you tell the difference between somebody with epilepsy versus movement disorder? Epileptic seizures tend to be paroxysmal, but movement disorders can be paroxysmal or they can be persistent. Keyword there is that epilepsy tends to be paroxysmal. It comes and goes, right? Nobody carries seizure and have seizures all day, all night. No. Movement disorders, once they have it, they have it. It might exacerbate or remit. But once they have it, during the exacerbation, they have it every single day. It could be for 6 months, it could be for 3 months, but it's persistent. You got that? Whereas in seizures, they are paroxysms. Seizures tend to last for very brief period of time, most of the time less than 5 minutes. And seizures may have sensory anomalies, whereas movement disorders are essentially motor anomalies. EEGs are usually abnormal in epileptic seizures, whereas in movement disorders, EEGs are normal, okay? Unfortunately, movement disorders can coexist with epilepsy, okay? So that makes your task as a clinician that much more difficult. We generally classify movement disorders either as dystonias or dyskinesias. What is the difference? Dystonia just means abnormal tone, okay? Abnormal tone. It could be high tone or low tone, okay? Pay attention to the word "dys" in medicine. When you say something is "dys," it just means abnormal. It could be high or low. So we say somebody has dyslipidemia. That means they have some high lipids and some low lipids. If we say somebody has hyperlipidemia, hyperlipidemia is a type of dyslipidemia. It just means everything is high. Okay? So dystonia are abnormalities of muscle tone. So you see, I'm standing, I'm talking to you right now straight because in my spine, my spinal muscles on the right and on the left, they carry the same tone. If for any reason the muscles on my right become hypertonic, I will go like this immediately. If it happens on the left, I'll go like this. If it happens in front, I'll go like this. So dystonias are abnormal movements that they arise from changes in body tone. They interfere with normal postures and movements, and depending on which group of muscles they affect, we call them blepharospasm. Have you met people like that? They'll look at you, and when they're talking, they'll keep going like this. Right? It looks like they're blinking, right? But they're actually having dystonia of their orbicularis oculi. They keep doing that. And then you have the oromandibular dystonia, and they keep doing stuff like that, right? And then you have the laryngeal dystonia, where the guy is talking. Do you believe that? I can't even believe I said that. His tone just changes in the middle of the sentence. That could be a form of dystonia, right? I don't have it. Now, cervical dystonia is when it has to do with the cervical paraspinal muscles. And then you have limb dystonias like writer's cramps, musician dystonia, and also from some dystonic tremors. Now, there is something about dystonic tremors that are important. Dystonic tremors are tremors that come from dystonia. Usually, this is for you to know academically. Clinically, it's useless because you have to do extensive physical examination to identify that null point. Generally speaking, when patients have dystonia, say they have dystonia of their right hand, there is a position that they will take and that tremor will disappear. But you have to do like full range of motion, take the muscles, look for the position of that hand where the tremor disappears. That position at which the patient exhibits no more tremor in dystonic tremors is called null point. Okay, so in exam, when they give you, there is, sometimes they will say null point, or sometimes they will tell you he suffers tremors, but when he raises his hand above his head and touches his other ear, there is no tremor. That is a description of null point. And that is usually your clinical clue to the presence of the dystonic tremor. Okay? Now, dyskinesia. Dyskinesia are abnormal movement, abnormal contraction. You can have too much movement or too little movement. So dyskinesia could be hypokinesia or hyperkinesia. Hypokinesia, two conditions, Parkinson's and Parkinson's plus, are the only two conditions that will cause hypokinesia. Okay? And then hyperkinesia, there are two types. They could be rhythmic or arrhythmic. Rhythmic hyperkinesia are tremors, and third eye dyskinesia. We'll talk about all this in a little more detail. Then when it is arrhythmic, you have chorea. Chorea, there is a fast type called balismus, or there is a slow type called acidosis. And then there is myoclonus, which is non-epileptic, and then there is tic, and there is ekathesia. Ekathesia. Let's take each of these. So that is an overview. Now, what is it that causes movement disorders? Remember basal ganglia? Remember I told you they are buried in the brain? And they actually are responsible for the execution of the motor command. They determine which muscle to inhibit, which muscle to excite to get you to do what you've decided to do in your mind. That requires very complex connection. So this diagram here is not easy to understand. I put it there so you know how complex it is. All I need you to know is that the motor instruction comes from the cerebral cortex. I'm going to pick a tangerine here. I made that decision. Immediately, my brain says I want to pick this tangerine. My basal ganglia immediately say, okay, you're going to need to extend your hand, pronate your wrist, reach down, bring your fingers together, lift it, turn it around. All that sequence of which muscles contract, which one relaxes, is done by the basal ganglia. Everything you see here, the striatum, the substantia nigra, the globus pallidus, these are all components of the striatum, and they are connected. This right here, they have direct pathways and indirect pathway, and some of the pathways are inhibitory, some are excitatory. What is the bottom line? The substantia nigra part compacta, which is a portion of the substantia nigra. Substantia nigra just means black substance, okay? And then it has a compactor part, which is a very compact. Under the microscope, you look at it, it looks very compact. So they call it par compactor, the compact portion. And then there is a loose portion of it under the microscope, and they call it substantia nigra pars reticulata. It looks kind of like spacey, not as compact. Okay? This substantia nigra, along with the caudate and putamen, that are components of the striatum, they modulate the cortical neuronal activities through the direct and indirect pathways to ensure smooth execution of motor command. So you don't need to understand all these complexities. I put it here purposely. Try to figure it out and you get a headache. Okay? All I need you to know is that the basal ganglia are responsible for the modulation of the cortical neuronal activity, and the intent is to ensure smooth execution of motor command. Now, that modulation requires excitatory pathways and inhibitory pathways. Movement disorders are direct results of neuronal degeneration and or neurotransmitter deficiencies in those pathways. Okay? So just the nutshell, that's what I want you to get. Basal ganglia responsible for modulation of the neuronal input. Many of those pathways are inhibitory, some are excitatory. It depends on normal neurons and normal levels of neurotransmitters. Any disease that affects neurotransmitter level or causes neuronal degeneration will create imbalance in those neuronal activities and result in movement disorders. Okay? So, dystonia is a basal ganglia dysfunction. How does it present? Mage syndrome, blepharospasm, oromandibular dystonia together make up what is called Mage syndrome. Okay? Bucolingual crisis, right? Repetitive chewing and swallowing motion. You have oculogaric crisis where the patient will go like uncontrollably, right? Just moving eyeballs like that. The laryngeal dystonia, you saw it in that guy when he was having a seizure. Torticollis, Have you seen that before? Like in in albinos, in albinos, they have a problem with their ocular muscles, and sometimes they tilt their head to maintain balance and avoid diplopia. When you see this type of movement in somebody who is not an albino, that is torticollis. Okay, that is a dystonia. Okay, and then you have epistotinus. You've done tetanus, right? You know what epistotinus is, right? Good, excellent. They have these cramps and limb movements. They're called limb dystonias. These are the ways in which, look, how dystonia presents depends on which group of muscle is affected. Okay, it could be anything from ocular to lingual to limbal. How do you manage it? You do EMG. With EMG, you can actually map the muscle. Okay? And then, how do you treat it? You have medical treatment and you have surgical treatment. Medical, most of the time, the commonest cause for dystonia are Reglan and Compazin. And these are medications. You remember what you use this for? Okay, Reglan is antiemetic, right? I told you what happened to me when I was an intern. I was called in the night. My patient was having nausea and vomiting, and she was on the hospital for gastroparesis from uncontrolled diabetes for a long time. So I gave her clopidogrel actually. Then during rounds, before round the next day, I just went to do my pre-round to see my patient quickly before they attend me, right? And I got to this patient, I said, Ms. Brown, good morning. And she looked at me, I'm like, Ms. Brown, what is going on? I was like, I called my senior resident, I'm like, I don't know what is wrong with this patient. I think we need a psych evaluation. So my resident came and said, what did you do? I said, I didn't know. Last night I gave her prochlorperazine. I said, oh, shoot. That is dystonia. Like, dystonia that quickly? I said, yes. 24 hours later, she was fine. You know, but it was that prochlorperazine that precipitated it. So many times, when you see dystonia, there is a medication the patient has been started upon that is causing it. So many times, there are dopamine blocking agents or dopamine precursors. Levodopa we use for Parkinson's. Its toxic effect is to give you dystonia, right? Now, botulinum toxin injection, botulinum is what you use to reduce toning muscles, right? That's why it helps with wrinkling, right? Okay. So you can use that. Or, see what they do. Get the surgeon to take the thalamus out, take the globus pallidus out, or take the roots out. So, in thalamus, they just take the entire, make a hole. You see, when they say thalamotomy is making a hole in the thalamus. When you make a hole in the thalamus, what are you effectively doing? You're disrupting nerve pathways. So it's not like it's not a thalamectomy. They don't remove the thalamus, but they poke holes in it. So by poking a hole in it, they are disrupting those nerve fibers, right? The same thing with pallidotomy. So you look at the globus pallidus and you poke hole in it. By poking a hole in it, not blindly, of course, strategically, because they've mapped it and they identified the pathways that are overacting and the pathways that are interfering with the movement, and then they poke holes through it, basically disrupting those pathways. Okay? And then rhizotomy is actually making holes in the anterior cervical root. When all else fails, deep brain stimulation basically tire the brain out. You look for that particular part in the brain where there is a lot of activity, and you stimulate it, and fatigue it. Get it, weigh it out. And patients get relief for maybe 3 to 6 months, and then they go back and get it done over and over again. You got that? Parkinson's disease. We've talked about Parkinson's disease, and in so many ways we've talked about it in dementia, but now we're going to talk about Parkinson's in and of itself. Parkinson's is a neuronal degeneration in the substantia nigra. Not in the striatum, in the substantia nigra. How does it present? In the early phase, you get tremor at rest, pale rolling tremors, relieved by movement. Very important that you realize that the tremors of Parkinson's are relieved by movement. That is the opposite of cerebellar tremors that are aggravated by intentional movement. Okay, very important, right? And then they have rigidity. The reason they look like their expression does not change is because the facial muscles are so stiff. So people are laughing around them. You can't see the smile. You can't see the frown because the muscles of the face are stiff. So they have bradykinesia, slow and less movement, loss of arm swing, less blinking. These are all evidence of bradykinesia. So basically, if you ask what are the early manifestations of Parkinson's, is tremor, is rigidity, and postural instability. Those are the three things. The tremor is typically a p-rolling tremor, real-time movement. The rigidity can manifest in the face as mask fascia, that is expressionless face. It could manifest as bradykinesia, meaning slow and less movement. Less movement, they walk like this. All flexed, they don't move, right? And then they don't blink as often as they should, and they also don't swallow as often as they should, and that is why they drool. Okay, it's because they're not able to swallow as often as they should, so they drool. And then resistance to passive movement is another manifestation of rigidity. And then they have the postural instability. So when they're walking, and you push them, they go and you pull them, you do the same thing. What is going on with you guys?
I just love watching your acting out.
All right.
You crack us up.
And then finally, so you don't have to, I don't have to give you a break. I have to keep you smiling. I don't have a lot of time. Finally, in the late phase, cognitive impairment, you get the Parkinson's dementia. Remember that? Evaluation. When you do MRI of the brain, you will see the absent swallowtail sign. I'll show you what that is in a minute. When you think that somebody has Parkinson's, like I just saw it, a 40-year-old guy with Parkinson's, I'm like, what do you do with Parkinson's at 40? Whenever you see Parkinsonism, so we call it Parkinson's disease when it fits the bill, the age, everything. But when you're seeing symptoms of Parkinson's disease in a younger person, like in their 40s, you call it Parkinsonism. Most of the time it's drug induced, okay? And you can actually confirm that by doing a functional brain scan, PET or SPECT scan, if you're thinking drug induced. How do we manage this Parkinson's disease? In patients that are under the age of 65 with minor motor manifestation, you always start with dopamine agonists. That's your first line. If your dopamine agonists don't work, then use your monoamine oxidase inhibitors. But remember, whenever you use monoamine oxidase inhibitors, and that patient ended up later on levodopa, your levodopa will appear to be overactive because monoamine oxidase inhibitors are needed to break down levodopa. So if you start your patient on monoamine oxidase inhibitor and then they ended up on levodopa, you will precipitate toxicity. So you need to have a good gap between the monoamine oxidase inhibitors and your levodopa. Now, if your patient has a severe motor manifestation and they're elderly, you give them levodopa. Levodopa is a dopamine precursor. Okay? So it's something we give to the patient, and inside the patient, like fosphenytoin, it is converted into dopamine. Okay? Remember, Parkinson's syndrome is dopamine deficiency, right? In the substantia nigra, right? Good. So you want to give something that stimulates the receptor or something that forms the dopamine, right? So that's why in the young people, we give dopamine agonist. In the elderly, we give levodopa. Now the problem with levodopa is that it is so rapidly broken down in the body that only 10% of it ended up ends up in the central nervous system where it is needed. That's what I mean by 10% central dopamine precursor. Right? It is so rapidly broken that 90% of it is destroyed in the body. And only about 10% makes it to the central nervous system. And even the arrival in the central nervous system is so erratic that sometimes it gets there too much and freezes your patient, or it gets there too little and your patient is widely symptomatic. So this fluctuation in the symptomatology of Parkinson's disease that is related to fluctuation in the entrance and access of levodopa to the central nervous system is what we call on and off phenomenon. Now, we got really smart. So we found out that what is actually destroying levodopa in the system that is not allowing it to get to the CNS is this enzyme called dopa decarboxylase. So we now, the pharmaceutical company now designed a medication called carbidopa. They made it in such a way that carbidopa does not cross the blood-brain barrier, right? It stays in the extracerebral space and blocks dopa decarboxylase. By blocking dopa decarboxylase, it inhibits the peripheral breakdown of dopa and allows it to penetrate the CNS and last a little longer. So most of the time, we combine levodopa with carbidopa, right? So that is what I mean when I said carbidopa, peripheral dopa decarboxylase inhibitor, minimizes peripheral side effects and boosts central bioavailability of dopamine. Okay? Unfortunately, these are the main medications we have for treating Parkinson's. And when this does not work, refractory case, we send them for deep brain stimulation. Again, trying to tire out the brain. And even there are times when that does not work, and you have to send them for thalamotomy or cardidotomy. Okay, basically disrupting those pathways. Got that? Good.
So for the minor motor manifestations, the under 65, do you give both of those drugs or just the one?
One.
Just one?
One, yeah.
Okay, so we start with dopamine agonists.
Yes,
Okay.
always. Okay. So you see, when you see the basal ganglia area, you see this swallowtail, right? That is swallowtail. So it looks like that. In patients with Parkinson's, right?
Very abstract.
It is not.
Oh, I see it. Look at the tail.
Oh, that part.
You got it?
Okay.
So you lose the swallowtail appearance. So it is the loss of the appearance that you're looking for. Okay? Unfortunately, we don't really. Parkinson's is not just about movement, it has a lot of other symptoms that you have to deal with. I told you about on and off phenomenon that comes because of fluctuation in the level of dopa, intermittent gait freeze and frequent fall. Because gait freeze is basically gait freeze. Somebody is walking upstairs and they just freeze. Their body is already in motion, but their feet is stuck to the ground. They will fall, right? So, how do you manage it? This is for information. When your patient is in the off time, you get a call from your patient's wife that your patient is frozen, he's not moving, he can't move. There is this preparation of levodopa, an orally disintegrating levodopa. You have to call it into the pharmacy. It works because it cannot give them a boost of dopamine and toss them out. Or you can actually use apomorphine, which is a dopamine agonist, okay? And once you freeze your patient off of that off time, you cannot prevent further occurrence by giving entacapone, which is a COMT inhibitor, okay? And what it does is to prolong levodopa effect. We'll talk more about that. Tremors in Parkinson's disease, you have to give anticholinergic. The commonest one is congentin, which is benztropine, right? And there are times your Parkinson's patient will go frankly psychotic on you. Again, yeah. Many times when they go psychotic, it is because of the dopaminergic agent. So overdose of the dopaminergic agent is what makes them to be psychotic. And of course, they present with baptism. I told you this already, right? If you think anything you're looking for psychosis, look for behavior abnormality, abnormal appearance, perceptual disturbances, thought disturbances, lack of insight, speech problem, mood swings. Baptism. Remember that. You will find it very, very helpful in practice. And how do you treat psychosis? Stop all the dopaminergic agents. When your patient with Parkinson's disease presents with psychosis, you stop all dopaminergic agents, including levodopa, dopamine agonists. And then you can put them on pimavanserin. That is the only medication. Terribly expensive. You just need to know that there is a medication for it. Remember I told you that whenever you see Parkinson's, you must look for drugs. There are all kinds of medications that can actually cause Parkinson's. It's amazing why we still use some of them. Diltiazem, amlodipine. These are popular blood pressure medications. They've been associated with Parkinson's disease, but we still give it to patients because high blood pressure will kill you before Parkinson's starts, or even before Parkinson's get to you. You see, this is what will humble you as a healthcare provider, because society puts so much value and expectation on you, but at the end of the day, you just realize that you're not really helping these people. You're just managing risk and benefit. You're not curing anybody. So that just, and if you, would you stop your patient and load the pain because of Parkinson's? Don't do what? You would. Even though I said, what should you do? You should discontinue offending medications if you can. Right? You can change it to beta blocker, but this is just an example of what we do in clinical medicine. Makes it tiring sometimes. I wanted to give you a good overview of the medications we use for treating Parkinson's disease. So I want you to know, DOPA is dihydroxyphenylalanine. It's an amino acid, right? Look, DOPA decarboxylase is the one that converts DOPA into dopamine, right? Either you stimulate dopamine or you block the metabolism of dopamine. Okay? These medications here, epomorphine, ritigatine, bromocriptine, carfentanil, trivalide, pramipexole, and ropinirole, they are all dopaminergic. Okay? Amantadine, used to use it to prevent flu, also dopaminergic. Now, Razagiline and selegiline, they inhibit monoamine oxidase and block the metabolism of dopamine into its byproduct. And entacapone and tolcapone block COMT and inhibit the conversion, the metabolism or catabolism of dopamine. So I just give you this so you can know how to place the medications, okay? Not for you to memorize them. You just need to know what does it do. So if you know that it's a dopamine blocker, then you know that's what it does. That's where it works, right? Okay. Stimulant, okay. All right. Then benztropine is just one of the anticholinergic. It's good only for the tremors, okay? Only for tremors. It does not stop the rigidity, just tremors, okay? And this is how it works. Block the muscarinic receptors and decrease tremors and rigidity of Parkinsonism. It does not really work too much for the rigidity. It works a hell of a lot more for the tremors than the rigidity. Okay? And I said this because I think it's good. Dopamine levels in the normal and the Parkinson's affected neurons. See, normal, see what happens in Parkinson's. So they have all this problem. You say, well, I always wanted to be one of the movers and shakers. I have been diagnosed with Parkinson's. And I said, well, shake yes, but move. Okay. Good. Now, are you tired?
Can we take a 5 minutes break?
Okay, I guess we'll go on till 2 and then I'll come back at 3. Yeah, I mean, we have to do what we have to do. So take a 5 minutes break. How's your project going?
So I went and I met with, Jamal.
Yeah.
I did the, volunteer work.
Oh, you
with them
did?
To see how they did
Okay.
everything. I didn't get to go to, so we made all the packs, but I didn't get to go down. To pass it out, but we're gonna meet, and I want to meet with the cars and all be on the same page. And maybe I'll meet with them.
Okay.
They're only making one. So for that, and then we're gonna all, but I'm waiting for them to give me, information about the money. So I can go to the barber. I'm willing to pay them.
Do we have an idea of how much it is?
No.
That is going to be important.
And like, I hope it comes, like, hard to the barber.
Yeah.
But I just have to.
I like the Emperor's stuff.
But the barber.
I like
And they're really good, though.
Was that-
They're
yeah,
really
yeah.
cool. Like,
I'm glad.
yeah, thanks for introducing that. Yeah, so, yeah.
You're so good at acting. I love it. Even the sound effects.
Thank you.
Oh yeah, I know.
So you still have comment on that thing?
Martin's please.
This?
They're like,
Yes.
but it's like a basic line. Where? Why are there so many buttons? I was like, it's like lights and then the mode of blinking. You have a night show, I think it's slowly like oh, they have the bulbs. Yeah, the bulbs are like
Oh my god. Is there a pink one?
there was like a boba.
I know, I saw. Yeah.
I was looking for.
So they were all, Saturday was the day they were all, they were dressed together, and then like, we found 2 or 3 others.
Did you dress up too?
No, I was just normal, cause like, I gave my roommate my shoes.
Yeah.
To wear, and then, but their group, they were some group costume, so that they were all.
Do you have pictures?
I don't have your picture,
Oh.
yeah. But then it's like when someone stopped them to take a picture with them, some other ones that were walking by came over like, hey, we are too. Like, Pops never let me
Yeah.
all.
You were special.
Taking pictures.
Thursday?
I
Did you
know.
guys go to USC for anatomy?
No. Yes.
No?
Yeah.
So good. Yeah. It was the best professor.
It was awesome?
She was like
Yeah,
my
she was a
favorite
really good
professor.
professor.
Really?
Amazing.
You know what we're going to do now?
What?
We're going to bring the cadavers
To
on
here?
campus
Where?
No.
and do the anatomy class in the School of Nursing.
What do you mean bring them? Or
Like the actual
you're
dead
gonna keep
bodies?
them here, or do you-
No, no, we'll bring the
them once a week?
cadavers for the class and they will remove them after class. They'll bring
You're
them
not gonna
every-
let them do the dissections, right?
They will.
You shouldn't.
Why?
It takes up too much time.
No, the professor will do the pre-dissection.
Oh, okay, okay. So we
So
just have
he
to
will
do-
come, so we'll be dissection every other week.
Oh,
How
okay.
many cadavers?
We're planning for 4 stations. So it will be like 6 students per station.
Oh.
So you get to
drives them?
There's a business called Science Care in Long Beach.
Oh, and they do that.
They will bring it, they will take it back, bring it, take it back. But the good thing is that it will be on campus.
Yeah, they don't have to drive there.
Yeah,
It's
that's
like-
what
They have to drive to.
Good man, I'm just trying to stay alive.
They're like, they'll do better than that.
I'm alive. It's just Mondays. It's tiring.
Mondays are terrible, right? I hate Mondays.
Yeah. It's a hard day. And then you get used to it.
Have you heard about Monday headaches?
Every Monday.
It used to be seen in patients that work in explosive factories where they're exposed to nitrates. So they get when they go home on the weekend, they are headache free because the nitrate washes out of their system.
Oh, that's
And then once they get back to work on Monday, the headache goes on till Friday.
That sucks. Oh my god.
It's called Monday headaches.
No, I don't have the recipe.
All right, I said 5 minutes.
It's okay, you can start.
Oh yeah, it's been 5 minutes.
We are ready to roll. All right, so there is a group of conditions called Parkinson's plus. So like you can imagine, that means the patient has Parkinson's disease plus something. All right? And there are 4 of them. Okay? This Parkinson's plus syndrome. You must know them because they're easy to diagnose. So if you find a patient, say for instance, a patient was brought to you. Let me tell you how I can paint a picture of Parkinson's plus to you. I'll tell you that here is a 70-year-old male with a history of Parkinson's disease, brought in by daughter following a fall in the bathtub. Physical examination, forehead bruising from the fall. And I'll tell you the blood pressure sitting was 160/90 and standing 140/85. And falls change from maybe 70 to 80. So I will paint a picture of positive orthostatic changes for you within the context of Parkinson's disease. That is usually how the picture will be painted for you in multiple system atrophy. If I want to throw a couple, I will give you ataxia. But the key thing there is that the patient has Parkinson's and then they have this autonomic dysfunction, usually clinically apparent from orthostatic hypotension. All right? Now, the second one is corticobasal degeneration. Generally speaking, Parkinson's patients, they have bilateral tremors. They're stiff on both sides of their body. When you see somebody with Parkinson's and they only have tremors in one hand, in other words, it's an asymmetric Parkinsonism. And then they have cognitive dysfunction, especially apraxia. You all know what apraxia is, right? Difficulty with the learned motor task. And then they have corticosensory deficit, especially this alien hand syndrome. You know what alien hand syndrome is?
No.
Alien hand syndrome is when patients do crazy stuff with their own hand and they don't have control. They believe that their hand is being controlled by aliens, right? So I will come here and I will go and I will steal somebody's mango. I will say, I'll eat it. And I'll say, this is alien hand, right? Okay? And believe me, it's real. Patients patients present with this stuff, what crazy stuff, right? Alien hand syndrome. When you see asymmetry in Parkinson's, and you have evidence of cognitive dysfunction in a relatively new onset Parkinson's. Remember that Parkinson's dementia is late manifestation of Parkinson's disease. Remember that. Usually it's the last thing after the patient has been Parkinson's for a long time. But if you have somebody who has been Parkinson's for 2 years and you're seeing apraxia, that is way too early. Cognitive dysfunction is not early in Parkinson's, it's late. When you see cognitive dysfunction, dementia in Parkinson's, early, you are probably dealing with corticobasal degeneration. So in an exam, I will give you a story of a recently new onset Parkinson's patient with a mini mental status score of 12. You know you cannot, that is not a regular dementia. That's a Parkinson's patient with an early onset dementia. That is more likely to be corticobasal degeneration. You got that? Mm-hmm. Okay. And then there is progressive supranuclear palsy. This is Parkinson's with vertical gaze palsy. Vertical gaze palsy is inability to look upwards. Inability to look upwards. So you're doing oculomotion and your patient cannot look up. When you tell them to look up, they can't. But when they have to look up on their own, without their own voluntary input, they do. There is something called Bell phenomenon. You see, if I hold your eyes, your eyelid open, and I tell you to close your eyes, and I prevent you from, I'll hold your eyelid open, you will notice that every time you try to close your eyes, your eyeballs roll upwards. It's a normal phenomenon. The reason you don't see it is because many times the lid closes, so you don't see the eyeball rolling. But if for any reason you develop a weakness of the orbital, what is that stuff called? Orbicularis oculi, and you could see the eyeball in a patient attempting to close their eyes, you see the eyeball roll up. That rolling up of the eyeball when you try to close your eyes is what is called Bell phenomenon. It's a normal protective reflex. So patients with supranuclear palsy, they have voluntary vertical gaze palsy, but they have preserved oculocephalic and Bell phenomenon. So when the vertical gaze is not voluntary, it occurs. But when you ask them to follow your finger and try to elicit it, it's not going to happen. So whenever you see vertical gaze palsy in patients with Parkinson's, you must remember progressive supranuclear palsy. The way you remember is that palsy. Okay? Progressive supranuclear palsy have vertical gaze palsy. You got that? So if you can figure out autonomic dysfunction with multiple system, because autonomic system is a multiple system, it's a multiple organ system, right? I'm trying to give you how you can associate it and remember it. Corticobasal degeneration, asymmetric cognitive dysfunction because of corticobasal, cortex. That is where you have your problem with dementia, right? So corticobasal is a cortical problem. So they have dementia along with their Parkinson's. Progressive supranuclear palsy, they have vertical gaze palsy. And finally, Lewy body dementia. You remember that, right? Good. Why do we put this in a special category? Because they're difficult to treat. They don't respond to medication. So if any Parkinson's disease patient is going to need deep brain stimulation or pallidotomy, it's going to be a patient with Parkinson's plus. Okay? They tend to be very refractory. Okay? So basically, why do you need to know that? Their granddaughter brings their grandfather to the clinic, and you're examining the man, and the man has Parkinson's disease. And then he has positive orthostasis. You know, this is a multiple system atrophy. You're not going to give them hope because your medication is not likely to work. So you prepare the family that you're in for the long haul here. Okay. So that's the point of this. Good. That is all about Parkinson's. Let's talk about tremors. This is all there is you need to know about tremors in one slide. I like this cartoon. I found it online. Oh, this is really cool. Because you know what? Tremor with organic cause. The first question you need to ask yourself is, how old is your patient? If your patient is under 40, something is really, really wrong. You need to look for a genetic disorder, especially copper toxicity. So you must measure serum ceruloplasmin and 24-hour urinary copper secretion. If that is positive, you're dealing with Wilson's disease. You can cure that tremor with penicillamine, which is circulation therapy. Are you familiar with all these terms I'm using?
Yeah.
Okay. If serum ceruloplasmin level is negative and you still have neurologic symptoms, you need to look for a metabolic reason for that tremor. You work them up. But that is generally a bad sign, okay? Like my patient with tremors at 41, I have no idea what is wrong with him. I just gave him a beta blocker and I pray for him. Now, if your patient is over the age of 40, you ask yourself, is this a rest tremor or is it an action tremor? If it is a rest tremor, you're looking at Parkinson's, okay? Very simple. If it is an action tremor, you're going to ask yourself, do you drink alcohol? If yes, there could be withdrawal. Otherwise, you're looking at a postural or intention tremor. Okay? Generally speaking, when it is a postural tremor, that is your essential tremor. When it's an intention tremor, it's a cerebellar tremor. It's very simple, right? So you just start with age. Under the age of 40, you're dealing with a toxicity, right? Over the age of 40, could it be Parkinson's, cerebellar tumor? You now talk about, is it intention versus postural, and you work them up. Now, if you suspect your patient has Wilson's disease, while you're waiting for ceruloplasmin, if you look in the eyes, you see these things called Kaiser-Fleschner ring. You hear about Kaiser-Fleschner ring? Okay, it's obvious. You can see it's copper deposition, and you can make that diagnosis right and then. You give them penicillin, and there is hope that they'll be fine. Now let's talk about third eye dyskinesia. Any questions on tremors? Ma'am, any questions on tremors?
I have a question.
Yes.
Mel, do you have any questions?
No questions.
Sorry, on history, the postural tremor, what are we asking for in particular?
Postural tremor is tremor that you get with normal postures. You're not trying to move anything. So I'm sitting down like this, I'm shaking like this, right? Even postural tremor. With normal postures, you're shaking. Yeah. Intention tremor is when you're trying to get this orange, right? Postural tremor is posture. When I'm not like, okay, let me give you an example of rest, posture, and intention. Postural tremor. This is a normal posture. I'm doing when I'm shaking, right? Rest tremor. Hi. Right? Intention tremor. You see that? When you have an intention to do something, then the tremor gets big. Right? When you're at rest, completely at rest, not trying to do anything, rest tremor. You're in posture, just going about your normal business, and you're shaking. That is postural tremor. All right, let's do third eye dyskinesia. Involuntary rhythmic facial and body movement. I hate this topic, by the way. We don't know what causes it. But somehow, there is this hypothesis that it's due to dopamine imbalance, but it's not natural dopamine imbalance. It's drug-induced dopamine imbalance. So third eye dyskinesia is a complication of treatment of Parkinson's disease, right? You say drug-induced dopamine imbalance. And remember, what are the medications that can cause this? Antipsychotics, like haloperidol, antidepressants, your tricyclic antidepressants. So prochlorperazine and all this Reglan, and then dopamine agonists, dopamine precursors, any medication that interferes with dopamine pathway, whether it stimulates it or suppresses it, will put your patient at risk for tardive dyskinesia. So if you're likely to see any movement disorder in practice in your life, it will be tardive dyskinesia. And guess what? It will be the one you caused by one of these medications. Haldol, tricyclic antidepressant, prochlorperazine, or metoclopramide. Because we use metoclopramide a lot in diabetics because of gastroparesis, right? How does it present? Tardive dyskinesia is a dyskinesia that has facial emphasis. Remember my patient? She had that tongue and chewing movements, piano playing, hand movement, lip pursing and smacking, facial grimacing, feet tapping, right? I found this in this chart here. I think it's helpful, but let me tell you how to read it. So, I told you that tardive dyskinesia is always due to dopaminergic, a neuroleptic medication that you're giving. So once you see a patient with tardive dyskinesia, the first thing you want to ask yourself, that is tardive dyskinesia on neuroleptic. So the first question you ask yourself is, do I need this neuroleptic that is causing this problem? Or do I not? Okay? If I don't need it, regardless, I'll stop it if my patient develops tardive dyskinesia. Whether it is mild or severe, I will stop it. Okay? And that's the end of that. If I need, not needed, stop it. Right? If my patient needs the neuroleptic, if my patient needs the neuroleptic, I will try to see, can I get by with reduced dosage? If I cannot get by with reduced dosage, I will add other medication to combat the tardive dyskinesia. Believe you me, this is for your information. Invariably, you will stop that medication and your patient will be fine. All right? When you send your patient to neurologist, they have all these medications that they can give them. I want you to remember valbenazine, this one, is the only FDA-approved medication for tardive dyskinesia. Every other one is experimental. Okay? Chorea. What is chorea? Chorea is actually a movement disorder, right? But the reason it has a special category is because it's an abnormal, involuntary, dance-like movement of the body parts. It's like dance, and you cannot suppress it. Have you seen chorea before? You've seen patients, most of the time, patients with cerebral palsy, right? And like those slow motion, but they're generally retarded kids. And their normal motion, they may want to be coming here like this and you'll be, you know? Stop. You know? So, that is what chorea is. It's dance-like, you know, like breakdancing when like Michael Jackson did that stuff. Yeah, it's like that is. So that's what we call those kind of movement, choreiform movements, right? But there are two types of it. It could be fast and it could be slow. Balismus is the fast one. Let me tell you the difference between balismus and antidosis. Balismus is like this. So you're like talking to somebody and they could go, or you could go, like just rapid, very violent movement, right? Usually of a limb. Antidosis is the slow twisting kind, all right? So look at all the causes of it. Autism disease, that is just for your information. It does not matter what causes it. We don't treat the cause because apparently we can't, right? So what can you do? You can give them neuroleptics or deep brain stimulation. If you can identify a cause for it, if it's drug, you stop the drug. Because sometimes, remember, chorea is a movement disorder and it could be drug induced. Okay? Many of these movement disorders, honestly, you just need to be able to diagnose it. So you can understand that I can't help this patient and send them on and just pray for them. Neuroleptics, terrible medication. They are like sweet and sour stuff, a lot of them. First generation that they still use in Africa. Second generation, no longer, we use some of them. And then, but now look, this second generation, the antipsychotics. Wait again, new onset diabetes, dyslipidemia. We use these medicines a lot. I just give you some information on why they call them neuroleptics, because they interfere with the psychomotor function, emotional, and they have this affective indifference. They numb your ability to respond emotionally to your surroundings. Okay? That's what neuroleptics do. Okay? They induce neurolepsis. They induce psychomotor slowing, emotional quieting, and affective indifference. Okay? These old ones are the worst kind. These newer ones are the better kind. But they are both bad for you as far as dopamine pathway is concerned. They can both be effective and they both target dopamine receptors. So which means if anybody asks you, newer and atypical neuroleptic are less likely to cause tardive dyskinesia, false. They are not, the reason they work is because they target dopamine receptors. If that's how they work, it does not matter how they do it. They will predispose the patient to tardive dyskinesia. Okay? That's the point of this slide right here. Now, let me show you movement disorders. Let me see if I can pull this off.
Yeah, I can do it.
Okay, thank you. Movement disorders. I just want you to see this neurology practice and see how.
So you have like the link on one side.
It's like post life.
I didn't get it. Yeah. I'm not going to listen to you. Just a second. So what kind of trauma is this? Good. Give me the volume. We have to, how did you get
72-year-old woman had.
Good morning, everyone.
A 9-year history of progressive Parkinson's disease manifested by a large amplitude rest tremor in arms and legs, marked bradykinesia, slow and shuffling gait, retroportion, and stooped posture.
Can you all see? I just want me to turn up. I can't even turn on light. Okay. Oh. What happened to the volume?
It keeps going in and out.
Okay. Don't worry, it will come back. Do you see that this is not really typical? Because that woman is not supposed to be shaking when she is moving. But you see how flexed she is? And you see that what the shuffling is? That is what Parkinson's looks like. Okay? You're supposed to have volume. I don't know what happened. Leave it alone.
No, I think it's probably the video.
Yeah, it might be. Don't worry. Did you see what happened when she put her hand behind her back?
Yeah.
Okay. This guy is trying to elicit retropulsion and propulsion. You see what happened? Retropulsion. That one I told you when you put it percent. If you didn't do that, the woman will fall.
This 68-year-old woman has a 10-year history of progressive gait and balance difficulties, bradykinesia, dysarthria, and dysphagia. These symptoms are unresponsive to levodopa-therapy. The complete ophthalmoplegia, retrocollis, and stridal hand deformities are typical features of PSP.
Progressive supranuclear palsy, also, right?
The 6-year-old girl with a DNA-proven diagnosis of Huntington disease was well until age 3 when she began to regress in her mental and motor functioning. She developed progressive ataxia, chorea, and was no longer ambulatory by age 6. This 14-year-old girl with severe primary generalized dystonia and jaw opening dystonia failed to respond to conventional therapy.
You said dystonia, right? But it looks like balismus, right? You see how complicated these things can be? Look, this is what, you lose tone in your muscle, you can be bent into any shape.
This 62-year-old man has a 12-year history of progressive chorea with documented family history of Huntington disease. Note the frequent use of voluntary movements such as touching face or adjusting glasses to camouflage the involuntary movements. This is referred to as parakinesia. This 60-year-old man first noted symptoms of Huntington disease about 10 years ago. In addition to chorea, he also exhibits mild but progressive dementia, pendular reflexes, and halting gait characterized by irregular stride.
They do everything to camouflage the movement.
This 59-year-old woman with Huntington's disease has a 7-year history of chorea, gait difficulty, and postural instability. She also has marked motor impersistence demonstrated by her inability to maintain tongue protrusion.
And try this. I just want you to stick your tongue out and try to hold it out. Now hold it out as long as you can. Okay, now move the tongue to the right. Okay.
This 52-year-old woman with Huntington's disease has a 5-year history of involuntary jerk-like movements that move randomly from one body part to another. This 32-year-old man has a 6-month history of generalized autosomal dominant dystonia involving chiefly his axial musculature and his hands.
He's not doing this by himself. This is just what is happening to him because of the imbalance in his tone.
This 11-year-old girl has a 4-year history of fluctuating dystonia, being essentially normal in the morning and unable to ambulate in the evening because of generalized, predominantly leg dystonia.
See what happened with his legs? The leg is stiff because the muscles just forbid her from bending knees. That is his teeth, right?
He does have times, but his face is still, but that, if we get the pain under control, he doesn't have these movements right.
See the peripheral spasms?
This 14-year-old girl has a 1-year history of right hemidystonia, which later evolved into generalized dystonia.
She's not holding her hand back. but the muscles are putting a hand back there. All right.
This 66-year-old woman with a 3-year history.
You have the link. So you see that, at least you see now what I mean by dystonia. When your muscles just go out of tone, they bend you out of shape. And depending on which part of the body, this could be terrible. Okay? Now let's go and talk about tic disorders. So tic disorders are basically sudden movements of one or more muscle groups. There are two types, simple or complex. Simple when only one group of muscle is affected. Complex when multiple groups of muscles are affected. Now, in terms of causes, they could be primary or secondary. Okay? When they're primary, they usually come up before adulthood, in childhood, right? They tend to be acute and they tend to be transient, lasting under a year. But they could be when they're acute. When they're chronic, they go on for more than a year. The commonest one of these tic called Tourette's is the one you need to know about. I have a video on Tourette's for you to see how horrible this disease can be sometimes, right? Many times Tourette's is associated with obsessive compulsive disorder and attention deficit. When you see tics in adults, most of the time it's due to Huntington's disease. Do you see how many times that neurologist mentioned Huntington's disease? Mm-hmm. Yeah, it's very common cause of neurologic disabilities. And then stimulant drugs. How does it present? Again, it depends on where the muscle that is affected is. It could be motor tic, it could be vocal tic, right? Motor tics, generally suppressible. It could be simple, like abrupt movements, like head-jerking, facial grimacing. It could be complex as in echopraxia, copying gestures of others. So the kid looks and somebody scratches their nose and the kid goes, like they're imitating. You think they're being naughty. Many kids have been beaten to death. They have tics because parents thought they were being stubborn or naughty. Okay? Or copropraxia, making obscene gestures. Right? Vocal or phonic tics could be simple grunting or sniffing, or it could be complex, like repeating oneself. Many pastors have tics, right? The vocal tic. If you listen to sermons, you see some pastors, they go, and I tell you, Jesus will save you. Jesus will save you. Listen to me, my friend. I'm telling you, if you want to go to heaven, you have to be saved. You have to be saved. They keep, after every sentence, they will repeat the last one. Repeat the last one, right? That is called polylalia. Okay? Echolalia is when you repeat everything you hear, right? And coprolalia is when you just say bad stuff. Tic is diagnosed by history and examination. You don't need a test, okay? And it requires for you to have multiple motor tics with at least one phonic tic. In order for you to diagnose somebody with a tic disorder, you must show that they have multiple motor tics and at least one phonic. Okay, so it's not enough for them to repeat what others say. They have to have a motor tic. Okay? Guess what? The best news is, how do you treat it? Clonidine. Clonidine. Let me show you an example of tic. You won't believe this. This is a British girl. Watch what Tourette's look like in real life. We can skip the ad if you when it's nice.
Setting the stage.
Biscuit? Why the word biscuit? Oh gosh, I wish I knew. Biscuit. Happy birthday! They want to be heard.
Sorry, guys.
It's like a sneeze. Once you let it out, it just erupts. Mind your please. Tourette's. Biscuit. 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 Don't say biscuit. 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 How does it feel physically? Tiring. Now they're helping kids. my mission is to change the world, biscuit one tick at a time. And music is helping them.
Can you hear?
The fascinating and, yes, confronting world of Tourette's. It can be as mild as an involuntary cough, a facial tic, even the way you sneeze. But at its most severe, it causes sudden and surprising movements and sounds, including foul language. It's embarrassing and completely uncontrollable, which is why the three brave people you're about to meet want to be heard. They want you to know what it's like. And a warning, they don't mean to offend, but some of their language may offend some viewers. Here's Ronnie Sadler.
So tell me what your Tourette's symptoms are now. What do you feel? What happens to you?
I often describe for everyone else who doesn't know Tourette's as it's like a sneeze that wants to come out and is going to come out, and you might as well just let it out. I also just describe it as, like, say, having a fizzy can and you're shaking it, and wanking. You have a fizzy can and you're shaking it, and it's just better to just let it go. Faggots. Buggeries. Once you let it out, it just erupts. And I think that's where I am with my Tourette's. To the Batmobile. Kick him in the nuts. Push him.
We first met Mr. Johnny in East London.
It's a motherfucking dingo. Alright, last one out's a wanker.
On the Underground, taking the train into town.
This is a Piccadilly line service to
Shitfell.
terminals 1, 2, 3.
For her fellow passengers, what she says is confronting.
Can we kill him yet? When can we kill him?
For her, it's uncontrollable.
We have to watch it.
Blisters and burns.
Cellulite.
Oh wow.
Further north in a Liverpool pub, Luke Montague is about to order a pint. It might take a while.
Bollocks! Bollocks!
Winkers! How does it feel physically?
Tiring.
Biscuits.
Back in London, Jess Tom is being made up for a performance that will
Biscuit. Ow! Biscuit.
take the biscuit.
Ah, biscuit. 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 Biscuit.
The word biscuit. Why the word biscuit?
Oh gosh, I wish I knew. Biscuit, why certain words, biscuit become text, is a complete mystery to me. Biscuit. And as well as being sometimes like a worry, like you worry what you're going to, what the next tip will be. Biscuit is also can be quite a delight. Biscuit. Sand. Help. I'm stuck down the well.
How do you go dating?
Wankers. I did speed dating once. That was interesting. This is like
Jess and Ruth have Tourette's.
Oh, he's cheating on you.
You see this, this is not fun. These people, many times, the people you see on the road, on the train, in the stations that act weird, many of them are sick. You know how many Tourette syndrome patients in the US might be in prison or get in a fight and they'll be tagged aggressors? Because, seriously, the guy woke up the guy and called him a faggot. That can break out into a fight and you'll be called the aggressor, right? You could end up in prison. And in California, if that happens to be the third time, you're gone for good. You see why the entire social justice prison reform thing is a big deal for us? We don't want people to behave like this, but many of these people are ill. We need to make sure that we're not in prison, putting people in prison that are supposed to be in the hospital. Okay. All right, I think the last one, ectasia, inability to sit still or stand or even lay still. Two types, it could be acute or chronic, depending on whether it's been on or off for 6 months. Many times it's drug induced. The causes of it are drugs. Again, those neuroleptics, antipsychotics, antidepressants, even when you've been on them for a long time and you're withdrawing them, and then treatment for Parkinson's disease. How do you recognize it? Constant movement. You know, some people, I had a student in the other class, I thought maybe she had akathisia because she could never sit still, you know. She stopped doing that. What is wrong with you? Be still. They just can't be still. They got to be in motion of some sort, right? This restlessness, right? Rocking back and forth, marching on the spot, compelled this movement, compelled by intense feeling of discomfort. One thing you must be able to tell from akathisia is restless leg syndrome. That might be in fact due to iron deficiency. Okay? How do you treat it? Beta blockers. But would you treat akathisia? Let me ask you seriously. How many of you would treat akathisia? Would anybody here treat akathisia? Why would you treat somebody because they're moving?
Unless it like.
They are not hurting anybody. They're not hurting themselves. If somebody, you have to stand and be marking it, but what do I get? Mark the all you want. What mobility are you preventing? Treatment is supposed to prevent mobility or death, right? If it does not, why you want to treat it? What is the point?
It's like you can go back to like migraines. Like they're not gonna kill you, but they're very uncomfortable.
Oh yes. Migraine causes the patient to have pain. Akathisia does not cause the patient any discomfort. They are.
There's like different levels to it. I know people that have migraines like every now and then. Their doctors don't treat them. They just say, like you even said, tell them to take OTC, etc.
Yeah,
so,
because
like,
it works about half the time.
But like if the patient's coming in and asking for some type of treatment because it's a nuisance to them, then why wouldn't you treat them?
If the patient comes in asking for treatment, I will let them know, okay, I'm going to give you a beta blocker, but long term you have the risk of diabetes mellitus, and you want to take that risk. You know what I'm trying to say to you is that sometimes you need to just be more thoughtful about what you treat and what you don't. Many times patients rely on you to guide them. So what are you trying to prevent? Embarrassment? Okay, look at that those people in that video with Tourette's. That is a terrible thing. Even though they are not hurt by it, they are at risk. She was on the train talking about killing somebody. That was a disease manifestation. Why can't we kill him? If that was before 9/11, you know what? Imagine if that happens on the plane. She will be wrestled down. She might break bones before they realize she was sick. You know? So all I'm trying to say to you is, in treating patients, especially for conditions like this that don't have a cure, the medication is going to be taken for life. You need to ask yourself, let the patient know. You're not going to dictate for them. Say, this is this condition. We don't know how to cure this. I can give you this, or you can just roll with it. You know, and have the patient decide on when they will or will not be treated. Okay. I have a video of akathisia, but it's not important. I've already told you, it's a one somebody's just marking on the spot like that. Okay, it's not a big deal. I want to talk about restless leg syndrome, because restless leg syndrome is very, I shouldn't say that. It's not very common, but you might see it. It's a relentless urge to move the legs, promptly relieved by movement. You just have this discomfort and you have to move the leg, okay? It runs in families about half the time. Iron deficiency is a very common cause of it, okay? If you're lucky, you find one, you just give them iron and will be gone. Okay, there are a bunch of other stuff that will cause it. It's very common in females that are over the age of 40. And it can, because of the movement throughout their sleep tends not to be restful. So because they don't rest when they sleep, they end up with fatigue, and daytime sleepiness. You know what kills them? Traffic accidents. Because they're sleepy during the day, they run into cars and run red lights and get killed most of the time. So you see, this one I will treat. Okay? There is another related disorder called periodic limb movement disorder of sleep. The difference between restless leg and periodic limb movement is the duration. Restless periodic limb movement lasts for less than 20 seconds and is a triple flexion movement disorder. So when you have restless leg, you have triple flexion, ankle, knee, hip, in sleep. Restless leg is just movement. It does not matter how you move it. To the side, backwards, does not matter. But in periodic limb is a triple flexion, extremely important. That's a very distinguishing characteristic. Okay, everything else is the same. How do you treat it? Guess what? See why I don't treat this stuff? Dopamine agonists. You give them dopamine agonists to treat periodic limb movement, you predispose tardive dyskinesia or Parkinsonism. You see why I get confused about? Leave these folks alone. Okay. And then, of course, gabapentin, some report that it works, but the jury is still out on that one. Okay? I have a number of questions. Let's see. Yeah.
Is restless leg syndrome like a subset of ACAT?
No, restless leg syndrome is a differential diagnosis of akathisia. And periodic limb movement is a differential diagnosis of restless leg syndrome.
So the ACAT?
Akathisia?
That one is just your whole body moving and restless?
No. Akathisia is just restlessness. It's not your whole body. Yeah. It's a part of the body. Right. It could be my assistant.
I'm just trying to differentiate, like if I have a patient that comes in and they're just like, they say they're constantly moving their, yeah.
Akathisia.
So how's that different from restless leg?
They're sleeping. The restless leg syndrome, they're sleeping. Akathisia, they are awake.
Oh, okay.
Right? Periodic limb and restless leg, they're sleeping. Okay. Restless leg, in sleep, any movement. Periodic limb, the guy is sleeping. You see that? That triple flexion thing, you see it. It's a definite movement all the time. And it's triple. But restless leg could be. But periodic limb is. Good. Let's see how much you retained. In which of the following types of seizure, where are you going? In which of the following types of seizure disorders is the level of consciousness preserved in the patient? Wendy?
Is it myoclonic?
Myoclonic. Everybody agree? Mm-hmm. Let's match this. So, with the treatment, what would you give a patient with chorea? Please tell me. Korea. You send them to Korea. Come on, guys. Okay. Partial seizure. Parkinson's disease. Okay. Generalized seizure. Valproic acid, right? No, remember? Carbamazepine is Tegretol. That's the one you use for the focal seizures. Right? And then valproic acid is the one used for the generalized seizures, right? So how about tardive dyskinesia? How about tic? So now, what is chorea?
Atypical neuroleptic.
What is the most likely diagnosis in a 24-year-old female who passed out while waiting in line at a grocery store? The husband who witnessed the episode reported that the patient slumped and exhibited intermittent twitching of the limbs independently at different times. The patient regained consciousness after about 30 seconds and wondered why she was on the floor. She recalled feeling faint and experiencing palpitations before she passed out. What happened here? Convulsive syncope. Exactly. That is the way it sounds when you listen to it. Which of the following anti-epileptic drug is associated with purple glove syndrome? Thank you. Let's match this one. Breast tremors. Rubral tremors.
We don't know.
Good. You don't know. You know. Postural tremors.
Essential.
Thank you. Intention tremors.
Cerebral.
Dystonic tremors. Dystonic tremors. Come on, guys. Cervical dystonia, exactly.
Yeah.
So rubral tremor is cerebral outflow tract region. Right? Excellent. What is the appropriate next step in the management of a 28-year-old female with 11-year history of juvenile myoclonic epilepsy, controlled on valproic acid for about 16 years? The patient has been on oral contraceptive pills for about 12 years and plans to get married and have children in the next year. She is concerned about the implication of her diagnosis and treatment for the safety of her baby. What would you do? Oral, right? You will start lamotrigine, you will take off valproic acid, you will stop oral contraceptive. All right? Excellent. Thank you. I'll see you guys at, come to come back at 3? Okay, I'll be back at 3. I'm going to leave my flash in there.
Oh, you thought I had missed his leg?
Something.
Oh, sorry.
No, excuse me. No, it wasn't at all. I'm telling you.
Oh, my dad was cook. My uncle always said. I mean, he prefers for my mom. Most of the time, my mom thinks, but my dad can.